Good morning. I'm Shazia Durrani, a geriatric psychiatrist based in Regina. My project aim was to improve the detection and management of delirium in elderly patients by 50% in an accountable care unit in Pasco Hospital, Regina. I have to say, even though we managed to achieve our aim, our ongoing work needs to be done to sustain this change. I work with other team members and see a lot of elderly patients in long-term care facilities. We noticed that many patients were discharged from acute hospital after a period of brief illness with ongoing antipsychotic treatment, yet they had no known psychiatric disorder other than dementia. We figured the likely cause was delirium. We therefore focused on assessment and management of delirium in elderly patients and worked with an accountable care unit. We created evidence-based order set and links to a treatment algorithm and assessment tools. We used driver diagrams and fishbone analysis to find the contributing factors. We provided education to staff and information to patients and family members. We completed 2 PDSA cycles and following that, had the opportunity to get our order set and assessment tools approved for use across the hospital and long-term care facilities in Regina. Our first PDSA cycle was for 5 weeks. The staff completed confusion assessment method tools on every patient in each shift. This obviously led to completing a lot of CAM tools. Hence, the unit manager had to provide follow-up. The positive tools were then discussed in the daily rounds, and the physician could then use the order set and algorithm as well as patient education. In our second PDSA cycle, we simplified the process by modifying the nurse's daily review chart. We included change from baseline as part of their mental status examination, and the change in baseline would then trigger the nurse to use the CAM tool, which she could then present at the daily ward rounds for the physician to use the order set and the algorithm. These are the total number of CAMs used on weekly basis across the 2 PDSA cycles. As you can notice, a lot more CAMs were done in the first cycle as compared to the second one. These are the total number of order sets or PPOs used on weekly basis in the accountable care unit for delirium. And this is a similar graphic presentation for the same process. We had staff feedback at the end of this process. The strengths were identified as early detection with standardized approach. It improved staff awareness and reduced the pharmacological interventions, as well as some staff felt it helped with early discharges. The barriers were the fact that the medication dosing schedule in the order set was somewhat confusing, and staff would prefer a scheduled dosing rather than PRN at the start. Everyone agreed that the use of CAM and PPO should expand to all other units, but further training should be provided, which is what we did. Staff training modules were provided, and physician education videos were prepared and provided across the intranet. From this process, I learned some key factors. I learned that it is important to listen to people on the ground to make a lasting change. A lot of time and patience is needed when we want to make a change that includes change in practice as well as working culture. In our project, we had input from the departments of psychiatry, continuing care, and hospitalist unit. And by working together from these 3 departments, we managed to achieve our goal. Therefore, teamwork is key. We had the support from my sponsors, my coach, the CQIP process helped us guide, and that gives us the privilege to work on this project. So on behalf of my CQIP team, I thank you all.